Hello, and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name is Anna Falanga, and I am a member of the RPTH editorial board. I work at the Hospital Papa Giovanni XXIII in Bergamo, Italy, and am the head of the Department of Transfusion Medicine and the Hemostasis and Thrombosis Center. I am very pleased to introduce Mrs. Anna Tran. She is a clinical researcher at McMaster University, involved in emergency and thrombosis medicine as a part of a research group with Dr. Kirsten DeWitt. She has collaborated with the numerous researchers on a variety of different projects, locally and abroad, at the University of Cambridge, including the After the Plague project at McDonald Institute of Archaeological Research, as well as a psychological impact of pulmonary embolism project with Dr. DeWitt and Dr. Ridley. The work she's presenting was recently published in a paper at RPTH entitled The Psychological Impact of Pulmonary Embolism, a Mixed Method Study. This paper has inspired the current science-themed waiver promotion happening at RPTH, as it touches on an important topic in thrombosis and hemostasis research and healthcare. Anna, we look forward to hearing your presentation, please.
Great, okay, let me go ahead and share my screen here. So thank you so much, Dr. Falanga. It's a great pleasure for me to present our recent publication in RPTH. And I'm excited to talk about our study, which, as the title suggests, looks at the psychological impact of pulmonary embolism. So the study's nickname is actually the PIPE study, which stands for the title of our paper. Essentially, we were looking at the lived experiences of those who had been diagnosed with PE. And this really came about because we had this kind of notion that some PE patients seem to be experiencing psychological distress following their diagnoses. So we wanted to dive into that and sort of figure out exactly why some patients were experiencing more of this distress than others. And what we found in the literature, most of which was actually research that was based in Europe, was that PE patients tended to score higher on depression and anxiety scores compared to controls. And that patients have reported symptoms suggestive of post-traumatic stress disorder, PTSD, associated with their thrombotic events. And there was even a term coined, post-thrombotic panic syndrome, which described this kind of hypervigilance of physical cues of their thrombotic events. And so our aim was essentially to look at the incidence of PTSD among PE patients, particularly in a North American, or more specifically in a Canadian context, to try and understand what kinds of factors could be contributing to mental and emotional distress following receipt of a PE diagnosis by documenting and really listening to patient stories and their experiences with their PE through the lens of PTSD. So all our patients were recruited from our local hospital thrombosis clinic here in Hamilton, Ontario in 2018. So it was about 3 years ago. And basically this involved me sitting in the clinic day in and day out, asking patients if they would be willing to complete a survey for our study via an iPad. And so this survey made up the quantitative component of our study and was based on an instrument called the PTSD checklist for DSM-5, or the PCL-5, which essentially worked to measure the severity of PTSD. And once the survey was completed, all the survey participants were also asked if they would be willing to take part in a semi-structured interview with me, where they had the opportunity to further expand on some of their thoughts and share some of their more personal experiences with their PE. So let's start with what we found from the surveys. So we had a total of 72 survey respondents, and you can see the age and sex distribution here. And 17 of these patients reported feeling more anxious since their PE diagnosis. So that's about a quarter of our sample. And what's more notable is that 2 patients scored above our designated cut point of 33 on our PCL-5 checklist, which suggested that they were exhibiting PTSD. However, thankfully, our survey showed that most patients in our sample did not report a lower mood, an inability to cope, or worrying more, according to the 4 statements that we posed to them in the beginning of the survey, which I'll show on the next slide. And perhaps this also has something to do with the fact that 64% of our patients hadn't sought medical advice for their mental health as well. So here are the 4 statements that we included in the survey, where participants were asked to score on a visual analog scale, a VAS, the extent to which they agreed with each of these statements. So for example, we have, since being diagnosed with a blood clot in the lungs, I feel more anxious compared to before the blood clot. We have, my mood is lower compared to before the blood clot. We have, I feel less able to cope with my life. And finally, we have, I worry more. And so you can see from this box and whisker plot here that most patients did not report a lower mood, an inability to cope, or that they were worrying more as a result of their PE, which is a good thing. So now, of the 72 respondents that we had, 37 of them thankfully agreed to complete an interview with me as well. And you can see the demographic data for them here. And what we found was that nearly half of our interviewees reported feeling psychological distress following a PE diagnosis. So some of the major themes that we identified as being associated with the distress were 1, physical PE symptoms, 2, how clinicians delivered the PE diagnoses, and 3, reliance on anticoagulation. So let me get into each of these. So we'll start with the first theme. So as we know, some patients experience more severe physical symptoms when they experience a PE. So for example, sudden dyspnea or tachycardia, which can be understandably quite distressing, particularly when it's unexpected. And we found that these kinds of distressing PE symptoms were associated with a fear of recurrence, anxiety, and hypervigilance. And we can see that here with Ms. Pembroke. And these are all pseudonyms. So Ms. Pembroke says here, it's something that's always on the back of your mind. And she was actually flying to South Africa at the time, and she was extremely stressed that she was having another blood clot, to the point where she convinced herself that certain bodily experiences were cues that she was going to have another PE, which of course is suggestive of her fear of a recurrent PE and her ongoing psychological distress. Now, theme 2 was essentially the idea that the way in which clinicians delivered a PE diagnosis could shape how patients understood and processed their PE. So many of the patients had never even heard of a PE before. And so their first impressions of a PE were, in many cases, entirely based on what their clinicians told them. And so Mr. Emmanuel, he says he wasn't overly concerned until the nurse said, "Is there anybody you'd like to call?" As if it was going to be his very last phone call. And what's more is that his doctor said a lot of people don't get through this, and that he was one of the lucky ones for surviving. And we have another example here from Ms. Maudlin, who told me this was one of the most traumatic things in her life. And it's really indicative of the idea that I think we tend to neglect these components of PE, and our focus is very much largely on how we treat it. And when the reality is that PE can be a difficult diagnosis to deliver, and we should really be giving careful thought as to what words we choose to use when delivering a diagnosis like this. And I had patients tell me that their doctors told them that they were a ticking time bomb. So word choice is definitely a very important consideration to keep in mind, I think. And lastly, we have theme 3, which was the idea that many of the patients I spoke to were very, very hesitant to stray off of their medication. So Ms. Newnham here is one particular example of a patient who was anxious to stop her anticoagulation. And she has a bit of an interesting story here. So she was in her kitchen one day and had her oven door open. So she walked around, she accidentally scraped her leg on the open oven door, which led to some minor bleeding. Now, the problem was that it bled and it bled and it bled for several days. And meanwhile, she kept taking her blood thinners. And so she explains why she continued taking them and said, "You're so scared in case you miss a pill and your blood is going to clot. if you're told to take a pill at 6 o'clock every day, you're taking that pill. And so we can see that there's that kind of great dependency on the anticoagulation from these patients. And so overall, compared to the literature, our study participants didn't quite experience the great deal of psychological distress that seemed to be present in other studies, such as existential anxiety, a lost sense of identity, and so on. But instead, we saw more symptom-related anxieties and fears of recurrent PE. And although we also saw that some patients were hanging on to lingering anxieties because they felt that they nearly escaped death, and some of that could be attributed to how their clinicians delivered that PE diagnosis to them. And with that in mind, I want to bring home the point that I think there's more we can do to help mitigate these anxieties for patients, and avoiding unnecessary reference to potential lethality might be a good starting point. We saw in almost all prior studies that a lack of expert information, poor communication, or disjointed healthcare provisions seem to be associated with negative psychological effects following PE. And so rapid access to expert care and advice should really be considered as a basic requirement for those who have experienced a PE. And of course, there were limitations to our study, including our limited sample size and the fact that we largely took respondents' accounts at face value. But our findings still raise the important question of how could patient follow-up more effectively alleviate back-of-mind anxieties. So of course, I think more work can be and needs to be done here. Although our findings may have slightly differed from other studies, the fact remains that psychological distress was common after PE diagnosis, and should be a reminder that our physical and mental health are very much intertwined. We often see mental health support services offered for cancer patients in oncology departments, for example, but it could be argued that all conditions should come with these services. And I remember speaking to this one patient who began crying during our interview, and she told me it was because she had always felt alone in her feelings of anxiety and depression. She'd never realized that there were others like her who'd experienced PE, who also felt the same way. And so being able to conduct a study like this has really been an eye-opening experience. And I'm hopeful that the more often we discuss these things, the less often people might feel so alone. And that's all. Thank you for your attention.
Thank you, Anna, for that great presentation. I have a couple of questions for you, and I hope you will take them. The first question I have is the methods that you have employed in the study are well described, no doubt. Would you please spend a few words, mostly for those who are not familiar with this type of research, describing the validity of these methods in this area of investigation and how they compare with similar studies?
So you're talking about the way that we analyze the qualitative data, is that right?
Yeah.
So essentially what happened was I had collected all of the interviews. I had them all transcribed by hand. And then what I did was I took them to be analyzed with a researcher at the University of Cambridge. So that's Dr. Redley in our paper, who is a sociologist in the field. And so we took a little bit of a different approach here, where I think typically in other qualitative studies of a similar nature, it's largely focused on coding the transcripts, developing the themes that way, and then waiting for theme saturation. And that's the usual method of going about it. But the way that we essentially did it was we had compiled all the transcripts. We had gone through them one by one on Microsoft Word. And so we didn't have the help of any kind of coding software, and we really took the time to flesh out all the responses. And I was working together with Dr. Redley for quite some time, going through these transcripts and seeing what kinds of things were common. And we had a lot of discussions of the different types of themes that we thought we should include within this manuscript. But ultimately, it was through going through the transcripts, coming to conclusions based on discussions that we'd had based on the codes that we developed for each transcript by hand, and then compiling them and eventually having the transcripts as quotes for the themes and the codes that we developed. So our approach was a little bit unique in that sense, where I don't come from a sociology background. And so a lot of that was with the help of Dr. Redley. And from there, we had Dr. DeWitt come in and sort of help us validate those codes and see whether they were consistent with what we thought. So that was sort of our process in going about the qualitative analysis there.
Oh, thank you. That was great. It's just my curiosity. Almost half of the patients in your study had an underlying cancer diagnosis. Am I wrong, or you suggest that the patient's stress was only partially attributable to their underlying cancer, which would be my first guess, by the way, but they fear the most pulmonary embolism? Is that you suggest that?
So essentially, yeah, so the hospital that we were at is actually a cancer hospital. So we had a lot of patients who did have a prior diagnosis of cancer. And I think coming into it, especially when I was first conducting a lot of the initial interviews, my impression was that they didn't seem to care very much about their pulmonary embolism diagnosis, and their focus was very much on their cancer diagnosis. So the first few interviews, they said, oh, you know, that was just a small thing. I don't even remember having that kind of diagnosis. And that's because a lot of them were incidentally found. So they were doing a routine CT scan and they happened to find a PE there. And so we didn't see an association between a cancer diagnosis and the level of psychological distress that they were experiencing. And it was later that I started to realize that there were more patients who thought, even though they had a cancer diagnosis, their PE was still the most traumatizing thing, not their cancer diagnosis. So because of that variation, we realized there wasn't that kind of association that we saw in our study sample, at least, between cancer and distress. Instead, it was related to the physical symptoms that they experienced of their PE. So those who considered that their PE was very traumatic often had severe dyspnea, you know, severe tachycardia, or they had fainted on the sidewalk. They had a lot of very distressing stories that they shared with us. And that seemed to be associated with their ongoing psychological distress, not their cancer.
Okay, that is a great work. And I thank you very much, Anna, for presenting this work and giving more insight into the psychological impact of pulmonary embolism. I enjoyed very much your presentation, and I hope that the viewers will read the full detail of your paper on our site, rpth.isth.org. And I hope you will continue to publish again in RPTH. Thank you all for watching, and please keep an eye out for the next RPTH research recap.